Hello, everybody. We'll finish up our chapter 22 and our second week of the quarter by our standard clinical applications of the lymphatic system and the immune function. And of course, we will not deal with COVID-19 because we just did that in an entire separate video. But we'll talk about immunosuppression or immunocompromise. It's a big thing with COVID now for a third booster. What does it mean? Well, we talked about in last week in the endocrine video, or the endocrine chapter, we talked about how important cortisol was as a glucocorticoid. And it's really important in that resistance part of the stress response. And it's really great. But we just said over and over again, remember, cortisol suppresses the immune system. Long term, it will suppress the immune system. So at the end of a quarter, if you've been running down the whole quarter, you might be worn down to where you're more prone to being sick. And that's what that cortisol suppression is. All the way, that's the milder version, and we could run all the way to the very final version, which would be SCID, severe combined immunodeficiency disease. And you guys probably know by now I don't like to put individual people or specific faces in these videos, but that's David Vetter on the left. And he's pretty important and pretty infamous, unfortunately. He's the boy in the bubble. He was born, I believe, 2 years after I was born. So he would be 2 years younger than I, but this picture had to be taken incredibly close to his death because he did not make it to 13. I believe he died at 12. He had a genetic deficiency called SCID, and he literally did not have the ability and did not possess a T cell or a B cell. Not a one. Not a single T helper, not a single cytotoxic T, not a single B. And you can imagine, and I've tried to impress upon you immune function, it's a day by day, at the most hour by hour fight to save your life. You can imagine what it's like without any weapons whatsoever. And so that is the bubble. He is in the bubble. He spent his first 12 years inside of a completely sealed, controlled bubble. Even just stepping outside for 2 minutes might have been enough to kill him with an infection that he had zero ability to defend against. So that's the extreme. And bone marrow transplants would have been a way and available to him at the time to try to get somebody else's B and T cells from the bone marrow. Remember, they're both produced. B and T cells are both produced from that lymphoid stem cell line in the blood marrow. And a marrow transplant will get you some, but the inability to proliferate and do all those things is going to be a long-term problem. Gene therapy now is where people are trying to look. Can we go in and fix those genes? And even as an embryo, can we correct the genes and put in genes that will produce T cells and B cells? Organ transplants. Just something to think about. I like this diagram. It shows you in the European Union, the kidney being probably half of all the transplants, and closer, even 2/3. Liver following closely, and then heart and lung become a little dicey, and then some of the smaller organs, if you will. So what happens? You remember positive selection in the thymus. You're testing the T cells. Your CD8 needs to recognize your MHC1 molecules. Your MHC1 are your self-antigens and self-presenting, your major histocompatibility complex presenting molecules. And the CD8 are your T cell proteins, and they need to be able to connect. Remember, you need to be able to lock things into place so that you can see if the TCR matches the antigen. But you also then at the same time, the epithelial cells in the thymus are testing the T cells. Say, okay, that's great. Your CD8 binds my MHC1. That's great. But oh, hey, what about this? Do you want to bind this? And it presents it with a self-antigen. And the TCR should not bind that. The TCR of a T cell should not bind that. And that's negative selection. And so if you're bringing in a transplant tissue, you're bringing in 10, 50, 100 billion cells in this new kidney, all of which are going to have MHC1 molecules. And those had better look really, really similar to the MHC1 of the host. They had better look really, really, really similar. Or else that binding won't happen, and those new cells will be recognized as foreign, and then it'd be rejected. So we talk about organ transplant rejection. So there exists a national, at least in the US, histocompatibility registry to try to look at the MHC of different patients and try to get the closest match. Obviously, an identical twin or a sibling genetically similar. Your siblings are not all genetically similar, but a sibling who matches up really well, like, oh my gosh, you look just like your brother, but nothing like your sister, that kind of thing. And that could really help too, to get two people matched up where their MHCs are really, really close to each other. And that will cut down on the chances that you will reject. It will cut down on the chances that the recipient will reject the donor organ, because that's bad. The lymphatic system, we've talked about it, and we've talked about the lymphatic capillaries collecting extra interstitial fluid, moving it into the lymphatic vessels, into the lymphatic ducts and trunks, and back into the circulatory system. And the lymphatic system, some people refer to it casually, totally casually, but as the sewer system. It just gathers up all the extra runoff, if you will, into the tissue, and it collects it and puts it back into the circulatory system, which is great. And if there are nasties that are, pathogens, microorganisms, bacteria, virus that are caught in there, they will be delivered through the lymphatic system, which is great because they'll go through those reticular meshes of the secondary lymphatic organs, the lymph nodes and the spleen, and all these antigens will be, and these pathogens will be presented to B cells and T cells, and that is really great. That's going to help you out a lot. But what if the nasty is traveling through the lymphatic system, which, by the way, gives you access to the entire body? What if those are broken off pieces of tumors? And that is, of course, metastasis, and that is bad, bad news. So a benign tumor is called harmless, not a great thing, but it's better than the alternative, because a benign tumor just simply means that it hasn't metastasized. A malignant tumor has taken off, and it dumped into the lymph system, and the lymphatic system is doing its job, which is going to be a major problem, and that is distributing those tumor cells throughout the body. And you can look at breast cancer. T category of the tumor, the primary inside of the breast tissue, is a horrific thing, but everything is relative. That is better than an N category, where it's moved to the axillary node, which is better than the M category. And in the M category, you've metastasized that breast cancer, breast tumor, breast tissue tumor into the bone, into the lung, into the liver. And you may recognize metastasis as there's this whole pattern. I won't go into any detail at all. But specific cancers migrate very specifically to other organs, and it's really when it starts to migrate or metastasize, that's when just all the world of trouble. That's your stage 4, really. Stage 1, stage 2 could be localized. Stage 3 could be starting to metastasize. I'm just giving you rough guidelines, but stage 4 is fully metastasized through the body, and at that point, unfortunately, you're looking more at palliative care, which is just really taking care of somebody rather than trying to cure. Palliative, making them comfortable in their last stages of these nasty metastasizing cancers. Anyway, I have this quote in the upper left. It seems like the corniest thing. It's actually from a movie. It's called Patriot Games. It's got Harrison Ford in it, and he's Jack Ryan. If you know anything about Jack Ryan, it's a whole series of action adventures, political thriller action, spy action adventures, and it's Tom Clancy, I believe. Yeah, Tom Clancy's a hugely popular American spy novelist. And I just think this is hilarious because this is an IRA terrorist, supposedly made out to be the nastiest person terrorizing Jack Ryan and his family. And I just love this quote because this is an IRA terrorist with a significant understanding of splenic function and immune function. It's just goofy. But in the context of this movie, it's just absolutely beyond absurd that a terrorist would say this to somebody. But he caused a car accident where Harrison Ford's character, his daughter, was in an accident, and there is no organ, unfortunately. On blunt force trauma, car accident, sports injuries, football, things like that, falls, there is no organ that is more poorly situated than the spleen to rupture upon blunt trauma. It is, you see it tucked just right underneath the rib cage. So any impact on the rib cage is going to really, really, really quickly sort of perpetuate right onto the spleen. And a ruptured spleen is a really bad thing because the spleen is tremendously vascularized, full of blood vessels. And so you may hemorrhage internally really, really quickly. And so a splenectomy, like anything else, it's an ectomy, is taking out. So tonsillectomy, taking out your tonsils. Mastectomy, taking out the breast tissue. Splenectomy, removing it so you don't bleed to death and tying off the splenic arteries, which is great to save your life acutely. But Remember, that's the main place where your blood is filtered, and all those APCs are presenting antigens to your B and T cells inside of the spleen. So without it, it's a long road fighting off infection, as this terrorist is mocking here. So anyway, kind of a weird thing, but what happened? What is this? Your physician or physician's assistant, and you might even be in a clinical setting where you might be doing this immediately to a patient. You're looking at the lymph nodes, and there's huge ones underneath the jaw. And what's happening is that massive levels of infection, massive antigen presentation by APCs, and then massive clonal selection is great. But there's not a lot of room in those lymph nodes for all this wild activity. And so they will swell up to make room to do all these things they need to do. And that, of course, is palpitation. Remember, percussion is making the sound. Oscillating is listening, and palpitation, right? Palpitation, feeling palpitation. And you can palpitate the lymph nodes to look for swelling. What are you looking for? You're looking for clonal selection. That's what you're really doing. You're looking for antigen presentation in massive quantities in clonal selection, because that will swell the lymph nodes. And then finally, autoimmune. And so this idea of the T cells, they should negatively select properly. They should be presented with that self-antigen, and their TCR should go, no, I don't bind that. That's me. But every now and then, because no system's perfect, every now and then some T cells go ahead and bind that self-antigen incorrectly. Some TCRs jump on it, and they are not shuffled through the apoptotic pathway. Those should fail and be destroyed, but sometimes they get through. And when they do get through, they're going to go through your body, and they're going to be recognizing legitimate body cells that are self. Your immune system is going to start recognizing them as non-self, and that it's just awful. It's just, we've been through so much in these clinical applications, and I try not to get depressed when we move through them, but it's depressing subjects, but this is what you guys are all about. You are the heroes that are going to deal with these things. And you know, you understand, when I was younger, my dad lost the very tip of his finger, just like I don't know, maybe a centimeter of his finger, because he thought there was something stuck onto the lawnmower, and he wanted to check, and he didn't really wait for the lawnmower to stop doing what it does, which is chop things. And so it was, you know, kind of like, oh, that's really tough, and, you know, a little time recovery, and, you know, you want to feel empathize and all that, but there's a lot of blame to be laid right there. Like, in, Dad, couldn't you just maybe count it out loud in your head to, I don't know, 8, and wait for the lawnmower to stop turning before you reached under it? So you feel bad, but you also realize there's not a lot of confusion in where the blame lies. My point to all that is, with autoimmune, it's just devastating. It's just devastating. It's your own body attacking your own body. It's just, I mean, all these clinical application things suck, but this is just another, in my mind, this is just another level. It's your own body just destroying your own body. Lupus, RA, rheumatoid arthritis, RA. We talk about all that beautiful synovial, articular cartilage in the synovial joint. It's beautiful hyaline cartilage lining the tips of the bones, so they just smoothly glide over each other beautifully. Unless your immune system decides that articular cartilage is some foreign thing, and it starts attacking and destroying it. And then you have arthritis, because the bone starts rubbing on bone, swelling, joint pain, all that awful stuff. MS, multiple sclerosis. Here's your myelin sheath on the left. Here's your myelin sheath on the right. Your body decides those myelin sheaths are foreign antigens, or foreign entities, and just starts destroying them. Nervous transmission just starts to fade away and become incredibly compromised. And let's just leave it at that. When your nervous transmission in your body is compromised, you know where that's going. And type 1 diabetes. So here are all your healthy insulin-producing beta cells in the pancreas and the islets, and then over on the right, your body just decides that those beta cells, and type 1 diabetes decides those beta cells are foreign entities and just starts destroying them. And we talked in this last week's clinical application, you may not even know that until 90% of these beta cells have been destroyed. That may be the first time you get any symptoms. So it just sucks, like your own body against your own body. It's not something you can point to. It's not something you can really rally against. Even cancer, you can sort of say, or COVID, you can visualize COVID as this evil, how hard do you need to visualize, as this evil entity that you're battling against. But with autoimmune, it's your own body taking you apart. And anyway, it's just very, very difficult. So Thanks for the week. That'll wrap up the lymphatic system with immune function, and we're going to jump over chapter 23 because we did that in 40B, and we're going to jump to chapter 24 and kind of end a run of 6 more chapters, or 24, 25, 26, 27, yeah, 6 more chapters, and it's on to digestive system and metabolism. Those are our next topics. So thanks so much as always, and see you next week.